Welcome to this webinar. Welcome especially Professor MOKDAD. We are excited with your contribution. Today we are covering a wide extension of the globe from the state of Washington in US to Georgia, Eastern Europe. First of all, I would like to inform that this webinar will be recorded and shared on the MediPIET website. For this reason, we will consider that anyone who will ask any question during the question and answer section agrees and gives his consent to be recorded and the video to be shared on the website. If any of you want to ask any question during the question and answer section without giving the consent to be recorded, please type your questions in the chat box and the moderator will address the question to the Professor MOKDAD. I would like to thank MediPIET scientific coordinators for launching these webinars and supporting questions and answer section today. And now I would like to give the floor to Dr. Carmen Varela from the ECDC, our scientific counterpart for MediPIET, since she was really helpful to contact Professor Ali MOKDAD. You have the floor, Carmen. Hello.
Hi. Thank you very much, Isabel. Thank you for this opportunity. Good afternoon, everybody. I don't know if you can hear me, actually. Yes, okay, good. So good afternoon, dear MediPIET colleagues, and good afternoon, Professor MOKDAD. It's really a pleasure and an honor for me to welcome you as an old friend and as a very admired epidemiologist to present your work. I'm sorry, now I'm getting a call. Okay. To present your work as part of this MediPIET COVID-19 webinar series, and of course to transmit the warm thanks of our network for finding time in your schedule, which these days must be incredibly busy. I know that you are in Seattle and you are presenting in the morning. We have all kind of time zones. So Professor MOKDAD is actually a PhD. He's a professor of health metrics sciences at the Institute for Health Metrics and Evaluation and Chief Strategy Officer for Population Health at the University of Washington. So prior to working at the IHME, Dr. MOKDAD worked at the US Center for Disease Control and Prevention, and he has published groundbreaking research on local level disease trends and leading risk factors for poor health. His work on obesity is also among the most highly cited in the field. You must have seen that there is in this presentation a background about the IHME, the Institute for Health Metrics and Evaluation, and its work developing this model with the intention of contributing to hospital preparedness and analysis of surge capacity. Later on, in early May this year, it was expanded to account for factors that would contribute to contain the spread of the disease and the possibility of resurgence. And with many locations passing their first peak of deaths of COVID-19, this webinar is intending to provide insights on usefulness of models for how best to prevent and manage a resurgence of the disease. So, Professor MOKDAD, welcome again, and you have the floor.
Thank you and good morning, everybody. So, can you see my slides?
Yes, we can.
Perfect. So, good morning and thank you for the introduction. Carmen, it's so good to see you. Yeah, we've been friends for a long, long time. I want today to talk briefly about the IHME COVID-19 model and how it has evolved through when we started until now. So I want to do a little bit the introduction of the model, its limitations, and the projection for some countries, and how countries could use the data, and what we are trying to do next. I'll be very brief in the presentation, and I have a lot of slides that I will leave it and I have asked that they will be shared with all of you. So if I skip some of the slides, because I want to give you more time for questions and answers. I'm presenting, of course, on behalf of a large team here that is working on COVID-19 from IHME, and it's led by our director, Christopher Murray. And what I want to talk briefly about IHME, many of you know IHME, but IHME is about 560 staff here at the University of Washington, and we work on three main questions. What are the world's major health problems? How well is society addressing these problems? And how we could best invest our resources to maximize our health outcomes and improve health. So background on COVID-19 estimation, how did it start here at the University of Washington? Originally, it started by a request from the University Medicine. We have several hospitals here at the University of Washington, and one of them is a big referral hospital, Harborview. We were asked by our hospitals here is to do projections for them so they can prepare for the surge for COVID-19. And their questions were how many beds we need, ICU and ventilators to prepare. So we started doing our models different than other modelers who have done models for COVID-19. Early on, we didn't know how many incident cases we had because we didn't have enough testing. So at IHME, we took a different approach. We said we can model deaths, and then we could see rates of increase in death rates, and then we could model that, and then we could reverse engineer from deaths how many beds we need, how many ICUs, how many ventilators. And then early on, we wanted to adjust, unlike other models, we wanted to adjust for procedures that each country is putting in place to reduce the burden of COVID-19. So other modelers early on assumed that be susceptible persons, the disease will come and infect them and it will go as high as possible. We said, no, there'll be measures put in place to address the spread of the virus. And we try to account for these measures as well in our modeling. The second generation of the model, and this model has evolved, of course, so now we're in the third generation. The second generation of our model moved from modeling only mortality death rates and their projection to what we call the suspected, exposed, infected, and recovered. SEIR models, we have two I here, and I'll explain what we mean. And we wanted to account for future transmission as well, because early on, we projected until August, and now we want to project after August. And then we started doing more and more out of sample validation from our models. So early on, we computed ratio of deaths in the last day of deaths, and then this death data to cases in the 8 days prior to when we are estimating, and we use this ratio to project the next 8 days. And then for locations, when we have hospitalization data, in many locations, we didn't know how many people were admitted to hospitals. So we didn't know when you have testing, is it tested for people who came sick to a health clinic, or is it people who are being tested out of a random sample or outside the clinics? So when we had these local hospital data, please mute your, if you can. When we have this hospitalization data, we use ratio of deaths to hospitalization as well in our models. And in our models, we have also individual simulation model where we use a specific death rate and age patterns of mortality. We used median time from transmission to death. We used hospital admission discharge alive based on ratio of admissions, how many were admitted and were discharged alive, how many died in a hospital. And we used ICU admission based on percentage of admission. And we used invasive ventilation based on percent of ICU patients. and we applied the median length of stay in a hospital to determine bed use, ICUs, and ventilation use. And the SEIIR model was infectious but not symptomatic, of course, for I. Infectious and symptomatic, we made distinctions because we realized that there are many people out there who are asymptomatic, but they are spreading the virus. And of course, everybody talks about R0, which is originally what the R of transmission early on, but we are trying to model effective R, which is RT, which that R changes with time. And early on in our early models, we were adjusting for temperature, population density, population mobility, and testing per capita. And the data for our models are different sources, basically time series of case and deaths, age stratified data. We have COVID hospitalization, we have testing, we have existing healthcare capacity. And of course, we had early on, we had data from people who came to us and gave us more data on like how many beds they have, how many ICUs they had. So states called us and updated our numbers. And we had social distancing measures and mobility data as well included in our models. Early on, we didn't have that. And then for early on in the model, what we had to do is 6 categories of social distancing mandates before we had mobility data, and I'll explain that. Early on, we added in our models priors to tell us once an educational facility is closed, what will be the effect on increase in death rate. And we included these in our model. And we had 6 categories of social distancing: educational facility closures, non-essential business order to close, people ordered to stay at home. We had severe travel restriction, like in Wuhan, China, they closed it. They didn't allow travel. Lebanon didn't allow planes to come. We had partial non-essential business order to close here in the US, and we had restricted group gathering. Later on, we had randomized mobility data. This is coming from Google, Facebook, Descartes Lab. And with these data, we don't have identifier. We add all these data from these 4 sources. SafeGraph is one of them, so 4 of them. We added them, and we produce right now mobility data, and we include mobility data in our models. We keep including these 6 categories of social distancing. If you're looking at the graph here, for example, before any start of any social distancing, this is in Colombia, for example, people reduce their mobility on their own. So we expect that variable is very important to include, because even when we reverse these social distancing measures, some people will stay at home until all of them is reversed. The people who stayed at home early on are very likely to stay at home until the end of any of these social distancing measures. In location where there are still positive cases, community transmission, we assume it will come back, that the curve will go back and increasing. We assume that transmission will return to exponential growth unless there are containment strategies put in place, which are widely available testing, contact tracing, and case-based isolation, and of course, restricting mass gathering. So basically, in our projections, now they are until August 4th, we will release next week until January. So we're assuming when COVID-19 re-emerges, these social distancing measures will be reintroduced again by countries and locations. We assume the second wave will depend heavily on how people they do and how good the protections that are put in place to slow the transmission. We are working on to determine how to model what may happen should a second wave occur, and we will release this next week. And then as the pandemic is unfolding, early on we were using the temperature, and we see a small and modest association between temperature. 1 degree Celsius was associated with a 2% decrease in transmission. Later on, as you will see in the 3rd wave of our model, now we found out that seasonality for pneumonia is more of a predictor than temperature, and we are using now seasonality as well. So in our models. And then we also don't know how government are likely to respond to second wave. So we will put what-if scenarios in these models for the next release. So more forecasts is coming from IHME and more scenarios. Some of the data I will share with you is not being released. On our web, there'll be all the data that has been released. Today or tomorrow morning, we will have new projections, and many of the data that I'm showing today will be released tomorrow. So we're having health system output as well, like whatever we have used before, and we are going to be producing the reference forecasts for as we think what will happen. So these are the three models that we have right now. Early on, we start with a curve fitting model, which we made a model to predict the increase in death rate. The second one was a combination hybrid between curve fit and SEIR hybrid model. Right now, I will explain what our KCS model is. So we're not using the curve fit anymore. We're moving the third generation of model. Let me explain why we are changing our models as the data is coming to us. Early on, we found out that the curve fit model was a great model to estimate the peak of mortality. And then we did a great job at IHME for every location we produced estimate for to project mortality and the peak of mortality. After the peak, the decline, we didn't do a good job using curve fit. So curve fit, we had to introduce the SEIR model because we have more testing in many locations right now, and we had more surveys about antibodies in countries. We have one in Netherlands, we have several that were conducted here in the United States, so we could do the SEIR hybrid model, and this model did much better in predicting the decline after the peak of the curve. So we needed the combination because some locations were still peaking, some locations were coming down. And not right now, we're moving to the third generation because we want to predict the second wave and what will happen with the second wave. So what is our KCS SEIR model right now? Is we're combining data on case correcting for trend in testing, hospitalization, and deaths. We do 1,000 draw on a daily basis in order to create the confidence interval around the estimates that we are producing. We use estimated infection fatality rate by age and the distribution of time from infection to death. And I have a graph, I'll show you this. Then we fit the SEIR model, and then we're trying to get a beta, which is the effective R, which is R not moving with time. So RT, beta T is the effective R. That's what we are trying to model. We use all the covariate, and I'll show you this covariate. What covariate we are using, we will forecast them in time and we apply them in the model, and we get this beta T, which is effective R, as we move forward. And we use effective R to estimate infection and deaths in the future as well. And we take a predicted infection and deaths and hospitalization use. So right now, as countries are increasing their testing capacity, of course, we're going to catch more cases. So we have to adjust for testing and reporting an increase in infection. So the true rate of increase in infection adjusted for the number of testing. Because if you test more, of course, you're going to find more cases. So here is a great example about how we use these NOT models. So here is cumulative deaths and daily deaths on top. You see daily deaths for a location, for example, here, Alabama. It goes up and down because that's not a fault of any health system. They are doing catch up, and we see less reporting of deaths, let's say on a weekend, Saturday, Sunday, Monday less, then Tuesday we see higher rate of reporting. So you see the deaths here, you try to average, it's going up, it's declining, and lately maybe it's going up. If you know what's happening in the United States, we had Memorial Day here and we had an increase in mobility. So the graph above it showed you cumulative deaths now when we do the NOT. So how it's going up. The second one is daily confirmed cases. And you see there is more cases being confirmed because, of course, we are doing more testing. And then we adjust these knots. Knot is like when you have a curve, you take 2 points and you get the line between them and so on around that curve that's going up and coming down. And then the daily hospitalization, as you can see, it was going up, it's coming down. You see maybe a little bit increase in Alabama. When you put the three together, this is the graph that you see. We're combining all these knots, and you can see right now how we are monitoring mortality, admission to a hospital, and confirmed cases. And we use the a mathematical, of course, science and computational algorithm. We have a high capacity for computational power here at IHME. We can do 250,000 of these models because we have so many locations. We have a lot of input coming in, and we include all of them in order to get an estimate for it. So what are the covariates that we are using right now in our model? So if population density, household size, we tried population, public transportation, urban slum, flu seasonality, and pneumonia seasonality. Mobility, mask use, we have data from Google on mask use, and you have seen some of those on our web page. We are also have data from Google of self-reported number of contacts. These are surveys, over 5 million respondents telling us how many of them wear a mask. I'll show you some of this data, how many report that they have been in contact with each other. And then we have the testing per capita, the mandates, and the sum of all these mandates, the 6 that I showed you. When we added all these variables and we check what association, at IHME, we don't force a variable on our model and estimate. We let the model and the data tell us what variable is a good predictor. So COVID-19 is not performing like a flu. Right now in the United States, if COVID-19 is behaving like a flu epidemic or a flu seasonality, we would see less and less flu cases. So we would see less and less COVID cases. It's acting more like a pneumonia. It's coming down slowly and it will go back again. So the variable that are staying in our variable, pneumonia seasonality and temperature, is out because pneumonia seasonality is more strongly associated with the prediction of COVID-19. Mobility from the Google data that we have. Mask use, we find we're doing a meta-analysis of mask use. We're seeing about 40 to 60% benefit reduction in transmission with mask use. Testing per capita, of course, and population density. These are the variables that are currently used in our models. So right now, some of the data that I want briefly to show you, this is the global as of June 3rd. Yesterday, I didn't update the numbers as of today. We have about 346,000 deaths. And then if you see the breakdown, North Africa, high-income countries, we have about 245,000 deaths. So let me show you briefly the mask use here. This is percent of people always. We have always and we have sometime. This is percent of people always wearing a mask. And you could see a huge variation. You could see Spain, you're doing extremely well, and Portugal more than in France. Italy is doing much better in wearing masks than in England and other parts of Europe. We see South America, which very well expected because right now they're going into their fall and winter season. The pandemic will increase with the seasonality. So people are more likely, and they are wearing their mask much more than people elsewhere else. And you could see in India, which is a very positive finding, that people in India are wearing their mask as well. China, we don't have that data. This is an estimate for China. We don't have the data for North Korea, China, and Cuba from Google and Facebook. This is the pneumonia deaths by week, and I want you to see the seasonality, and you could see it how it's go up. It comes down slowly in the summer season, then it picks up again. And we're seeing right now the same patterns with COVID-19 as you would expect to see by a pneumonia deaths by week. This is COVID daily testing per 100,000, and you could see a huge variation in testing. There are places that are testing more than 300 cases, 300 persons per 100,000 population. Even within our country, my state is not doing as much testing as, for example, what you see in New York or in other places as well in the country. Europe, again, there are variation. England is doing more testing than France. Spain and Portugal are going, okay testing in terms. We expect that you need more than 300 per 100K in order to be able to do the tracing and the isolation and detect a outbreak. As this virus is coming down due to seasonality, you will expect to see outbreaks here and there because people are moving around and about. So testing is what we need right now to contain the virus as we move forward. This is cell phone mobility data. I'm showing you here a state in India and Western Cape and South Africa, you could see how much mobility used to be and how much it declined when COVID-19 appeared. And then it's increasing right now. We saw that rate of increase in the United States in first and second week of April, even before the relaxation of any of the social distancing measure. People, of course, are getting tired and sick of staying at home. They want to go, understandably, they want to go out and work, but also in anticipation of the relaxation of these measures, people started moving out. So if you go back early on when governments were talking about putting in place these social distancing measures, people started staying at home even before we put them in place. And certain people are starting to going out right now, even before we relax this. This is mobility forecast as of June 1st, and you could see the decline. As expected, you could see a lot of decline still will remain in Southern Hemisphere, where you would expect right now COVID to be rising. You will see in Argentina and Chile, the places that are moving, and parts of Brazil that are moving into winter and fall, there'll be more mobility. You see places that mobility is declined, where there has been a huge outbreak in Saudi Arabia and Egypt. There is a lot of reports of deaths. India, of course, because they have strict measures of forcing mobility to stay at home. I have to admit here in mobility, because we're using smartphone, we're underestimating the decline in mobility in poor countries, because not everybody has a smartphone. So yes, in Africa, we may be underestimating how much mobility is going on in Africa and certain places, of course, in India. But this is not an issue for all of us in Europe or in the United States, because most people have, there are people who don't have a smartphone, but the majority of people have a smartphone. The effect of mandates is a little bit difficult for us to examine. All mandates, if you look at here by all countries, all mandates came almost about the same time. All countries started introducing these mandates within a couple of weeks. So you see all these mandates coming at the same time. And then right now in the United States, you see all these mandates are coming out about the same time. So it has been very hard to use mandates. If we didn't have mobility, we would have had a harder time in modeling the projections for COVID-19. So some of the limitation, we have still, many countries are not reporting deaths. There is underreporting of deaths, as we all know, especially countries that don't have good vital registration system. Even in countries in Europe, like France, for example, we know there were delays in reporting deaths from nursing home. In England, this has happened. So sometimes deaths occurring outside the hospital are delayed and report impact our modeling. And then many countries, like in many states here, for example, New York started adding presumptive deaths. These are people who are dying from symptoms, COVID-19, but they were not tested as well. And then we are not capturing the expanded capacity in hospitals. Like in our hospital, for example, at UW, we stopped elective surgeries and we moved some of our recovery room after surgery and our operating room to be ICU beds. So we're not capturing that. We rely on updates from countries. There is under-testing and under-reporting in many countries. We know that. These tests, we have to admit, are very expensive. We're talking about $40 to $100 per test. So many countries don't even have the capacity to do the testing, the reagents, but also don't have the financial means to do these testing. We don't know immunity, if there is any immunity, if there is any genetic role here being played. We have no idea. It's to be seen. This is a new virus. And of course, back of our mind, there is a balancing act between your economy and saving lives, especially in poor countries. So underreporting of deaths is a very big issue. So if you look at excess mortality, where we have data, this is in Spain, and then this is in Ecuador. In Spain, for example, we can tell how much excess mortality, the red, and then how much confirmed COVID deaths. And then part of this excess mortality is, of course, COVID-19 deaths. But you could see the difference is not as big. It is there. And yes, there is a huge difference that we have to account for, and we will revise this estimate. Every country will revise their estimate. But in countries where we don't have good vital registration, Ecuador, for example, there is a huge difference between reporting of COVID deaths and excess mortality. And now IHME is using excess mortality as well. Now we're modeling the probability of effective R to be above 1. So, and here is the probability. So it's like goes in Brazil by state from 0.4 to places where it is over 1. We are like sure that it's above 1, and then the virus is increasing exponentially. And you could see here there is a huge variation. Brazil is a concern for us. There is an increase in daily deaths. We're projecting an increase in cumulative deaths. And we are projecting, of course, that there'll be more increase in infections and daily and cumulative infections. This is effective R in sub-Saharan Africa. Again, you see an increase. Places it is Niger, which is, again, we don't have as much data, but some of the data that we are looking at, it doesn't look good for Africa. And there is a big concern about what this epidemic will do in Africa. In addition to deaths and mortality, delay of vaccination, prenatal care, HIV care, and so on. India, again, this is states in India. You could see that's a huge variation, but places in India R is bigger than 1. And we would expect in India an increase in infection and increase in mortality. Mexico, the same way by state. There are places in Mexico that are facing a big states that are we're seeing a large increase, and we're expecting an increase in infections and, of course, in deaths. Europe, these are by countries. Some European countries are doing much better than others. Denmark, Romania, Slovenia, Poland, Belgium, much better than other countries where you see with Cyprus, Portugal, and Sweden. Of course, Sweden is the biggest case that everybody is looking at it. So you'd see that there is effective R is increasing in these places, and it's to be seen. I'd like to talk a little bit about Sweden, because here in the US, it's a big debate about Sweden, whether Sweden not locking down, that they will have a herd immunity. All the studies we have right now about antibodies in Sweden is not that high at all. And the study that we have about antibodies in New York City, we found out it's 21% have positive for antibodies. New York City has over 25,000 deaths right now. So it's a heavy price to pay for getting to 21% or 30%. And herd immunity is a concept that all epidemiologists, we should remember. It's for vaccination. Once we have a vaccine, and we have people who are vaccinated above 80 and 90. This is when herd immunity we will get. Herd immunity from COVID-19 mean a lot of deaths, unfortunately. This is Italy here by regions in Italy. You could see again in Italy, there are certain regions that are still above 1, but in areas it's 0. It's not above 1, so it's below 1. And you could see the result is that there is a decline in infection that we see. Testing is increasing in Italy. This is the bottom daily infection and testing. And you could see that we are projecting that there'll be an increase in infections because of the easing of the social distancing as well. Deaths will keep on declining, but it will start increasing again, unfortunately, with the relaxation of social distancing. And this is the part that we will be modeling until January in order to provide what will happen. This is Lombardia, Italy. This is reported cases. You could see it's coming down. Reported deaths, it's coming down. And look at mobility. Mobility came down by about 80%. And each line is a social distancing in place. So mobility started declining before the first social distancing. And as they are easing, some of them in anticipation started going up, and you could see it now it's going up. And we are assuming it will be leveled because some of these people here who stayed at home, first, they can't afford to stay at home, they can work from home, or they are concerned. Some of these people are gonna stay at home until everything is clear in Italy or in this area. Germany, again, huge variation in Germany in terms of infection, but overall Germany is coming down. We'll expect it to keep coming down. The reason Germany will keep coming down faster than what we have seen in Italy, we're projecting it coming down, is the testing. Germany is increasing rapidly its testing capacity and doing more testing per capita than other countries. This is Spain, where most of you are. This is our regions in Spain. There are still some 1, 2, 3, 4, 5, 6 regions that we believe R is over 1, but still Spain has increased its testing. We are projecting by August 1st about 26,000 testing per day. So it's coming down, the cases. They will still be coming down. Mortality will still be coming down. We have to wait and see what will happen after August 4th right now. This is the United Kingdom, and you could see the test per 100,000 and all Europe as well, huge variation in Europe in testing. And as a whole country, this is the UK here. And then what you could see is also testing is increasing in the UK. We expect the same decline in the UK. Now, let me show you some of the numbers that the global that we will be releasing. We would expect right now about 734,000 deaths. Central and Eastern Europe will estimate a lot of infection and about 24,000 deaths. High-income countries will expect 321,000 deaths. Latin America is a big concern, the Middle East as well, and South Asia and Sub-Saharan Africa. What we are planning, what our models can be used for is planning for surge capacity and preparing for the next wave. They can be used as well in order to mitigate the second wave and reinstate some of these social distancing measures if we have the right projections and telling people what to expect as we move into the cold season in Europe and in the US, and as what we are seeing unfolding in South America and where fall has started. We are lucky that summer is starting here and in Europe as well. Of course, we will improve our data if we have more data, will improve our models, and then we are constantly seeking feedback from collaborators in order to improve our model. White House has been using our models. The slide behind the president here and his COVID-19 team, see the vice president, the president, the BRICS, and Tony Fauci. You could see IHME models. We have been used a lot. EU has been using our models, and we have feedback. We're going to release the next third wave of our model, and we're going to extend it to December 31st. And we are evaluating, doing quality check on our estimates right now. But next week, we will release all these models. We have been, I'm not going to show these slides, but we compare how our models perform compared to other models. This is a weekly error, cumulative errors, and these are the imperial model, Los Alamos model, and there is a gentleman here at MIT who does modeling as well, Yu Young. We compare ourselves to this model. We will release all of these on our webpage as well. This is what I wanted to present. This is my email if you have questions, and I tweet sometimes about our new data. So if you follow me, you see what updates I'm doing. I'll stop here and take questions. Thank you for listening, and thank you for all your support. I know some of you have been commenting on our models and providing data. Thank you very much.
Thank you, Dr. MOKDAD, for such a comprehensive and excellent presentation. I personally will need some time to assimilate it, but question and answers are open. So if you want to participate by addressing a question, oral question to Dr. MOKDAD, the floor is open. Okay.
Yes, I have a question. Anne-Sophie here. Anne-Sophie Le Carré here from the Joint Research Center. Thank you for this nice presentation, Dr. MOKDAD. I wanted if you could explain a bit more what would be the influence of temperature on the model. You said that you were using it, but what is exactly the impact of temperature of this COVID-19? Is it through the fact that people are more outdoor or through the resistance of the virus? Could you explain a bit more?
So what we did, very good question. What we did is we added temperature as it was increasing in the United States in our model. And we've seen an association between our data. 1 Celsius increase in temperature was associated from our data with 2% reduction in transmission. We didn't know what it is. Is it the fact that when temperature is increasing, people are coming out more? And then we know from the United States and other countries that transmission is more likely to happen indoor than outdoor. So we don't know, is it an impact of people being outside and people who would usually tend to sit together or gather, instead of doing it inside, they're doing it outside where transmission is less likely to occur? Or is it the fact that temperature itself is impacting the virus transmission? We really don't know. We didn't have the data to look at it, but we have seen in our models the correlation between temperature. Right now, we're not using it because when we put temperature in our model and we put it with seasonality of pneumonia, temperature is not significant. The seasonality of pneumonia is more a significant variable, so we drop temperature.
Another question, Dr. MOKDAD. You mentioned that people's behavior and testing policies are key. But I'm impressed about the data you showed about Spain. What kind of sources are you using to collect testing policies and especially mask use in different countries?
Very good question. So we have data from Google, and Google has a survey that they ask people who are using it, and we have 5 million respondents. They do this on a daily basis, and on these questions they came to us, and we signed a memorandum of understanding with them, and we're collaborating with them. So they added these questions about, do you wear a mask always, sometimes? They ask questions when you go out, how do you try to keep a safe distance from everybody else? So we're using this data. And as I said before, unfortunately, this data will overestimate the wearing of masks and overestimate the staying away from each other, because people who use Google are people who have a smartphone. So in poor countries, for example, in Yemen or in Egypt, not all people have a smartphone, and they are more likely to be out and about because this is their jobs. These are workers that they have to come out and work. So we don't know. So we maybe are overestimating it in places where there is poverty and economy, GDP is very low. But for like country like Spain, it's a very good estimation of the practice in people. And we could see that change from one day to day.
Okay. Thank you very much. Is there any other questions?
I know this is a lot to present in like a few minutes, and I'm sorry. And I tried not to have models, but I wanted to provide you a background of what we do and how we do it, and how it can be used and what variables we use.
Okay, thank you. It will be welcome. So I give the floor to the scientific coordinators in order to read the question and answers.
Thank you. So please feel free to, if you have questions, to raise your hand and we will give you the floor, or also to write them in the chat. So I'm gonna start reading the first question. Actually, there are 3 questions from Romana Hanef. She says, thank you very much for this interesting presentation. The first question is, why did you use the mortality data and base it for your model to predict the beds, ventilators, IQ?
Very good question. Early on, when we started our models, in every country in the world, we didn't have enough testing. So we couldn't tell how many people are infected. And we felt if we assume, like if you look at imperial model early on, they assumed that all of us will be susceptible, like 85, 90%. And they put scenarios for infections. We didn't have that. So we decided the best approach is to model mortality. And if we model mortality, because we know, especially in many countries, that Europe and the US, that there's a true reporting of COVID-19 mortality. So we were more confident about mortality as an outcome rather than infection as an outcome. So we modeled mortality. And then we figured out that we can go from mortality to how many beds you need, because we know from data in the United States, many hospitals, and from CDC, how many cases were admitted and how many people died. So we know from every death how many admissions there were. Early on in the United States, for every death, there was 11 admissions. So we could say 11 admissions. We have the hospital length of stay in the hospital. We took the median of it. We knew among those people who are admitted, those 11 for each death, how many were in ICU, how many needed ventilators. So we could do the reverse engineering, and we get a good estimate of how many we need for a hospital, and then we work with every state and every country to get this data. And we have at IHME a larger group called the Global Engagement Team, that they have collaborators all over the world. This is part of our Global Burden of Disease collaborators, over 5,000 collaborators globally. We seek data and we get the data from them. So we felt it's a safer way, and that's why our models were used by everybody early on, because we decided to use this approach and not to use susceptible, exposed, infected, and recovered model. Back to you.
Thank you. So there was a second question related to that one. Did you use the cumulative mortality data or COVID-specific deaths? In the first case, may that overestimate?
No, we used COVID deaths only early on. We didn't have excess mortality at that time, especially in the United States. And so we used COVID deaths. And yes, it is a very good question. Early on, we were underreporting COVID-19 deaths in the United States, especially even in Europe, especially the early deaths, because nobody expected that COVID-19 has arrived to the United States until the first case and death was announced here in Washington State, in my city. If you remember, in California, they went and did autopsy on deaths even before the case in Seattle, and they found COVID-19 in the 2 cases that they examined. So yes, we underestimated COVID deaths early on. Then when state here started adding presumptive deaths, these are people who died with symptoms of COVID-19. And if you follow the CDC here in Atlanta, Georgia, they changed the definition and added more symptoms for COVID-19. So we had, in one day, New York City added 3,000 deaths that were presumptive deaths. So early on, yes, we were underestimating. Right now, I expect that we may be overestimating with some of the presumptive deaths, but still, as I showed you in Spain and in many countries, if you look at excess mortality, yes, we are still underestimating COVID-19 deaths, because many of the people who are dying from other conditions right now could be as a result of delayed care or services from COVID-19 or COVID-19 co-infection. Back to you.
Thank you. Third question, you mentioned SER plus death hybrid model for effective R. Could you please mention which method you applied to estimate R, exponential growth or maximum likelihood, or time-dependent methods? These are the classical methods used for the estimation of R.
It's time-dependent method. That's a very good question. And let me show you what it's called. I briefly promised to. So we're using random knot combination spline, which is RKCS, which is a time-dependent model, and we're fitting what we call here meta-regression, Bayesian, regularized trimmed model. And then for the residual, we use ARIMA, which is autoregressive integrated moving average, in order to explain some of these spline between one and another. So I hope I answered that question. Back to you.
Thank you. We have another question for you. Have you studied the possible correlations between severity mortality in certain areas and higher air pollution or other environmental factors?
No, we didn't. That's a very good point. So we have the data on, we have actually from GBD data, we have historic pollution data, and we have satellite data, and we have the local stations when they measure pollution. We could add that in our model. That's a very good point. No, we didn't, because we assumed that all of us have seen that pollution has come down tremendously with the lockdown. And even like their photos of California, Los Angeles, where right now you could see from a mountain, you could see the city. So, but that's a very good point. We looked, I didn't want to talk about it. We looked at tobacco and we didn't see an association between tobacco or COVID-19. There's some people who talk there is a protective effect. We didn't see it. That's not true at all. Good question. Thanks.
Thank you very much. I'm taking advantage of having the mic to ask you another different question. Is there any possibilities for countries? So you're including more and more countries in your projections, for some of the MediPIET countries to eventually contact you or partner with you for get projections on their country?
Yes, definitely. Reach out to us. We would be happy to work with you. And we are trying to release all countries next week. And for many countries, we still have a lot of questions in our data. For example, yesterday, Carmen knows half of me is from Yemen, half of me is from Lebanon. I tweeted our numbers before we released them about Yemen because I'm concerned what's happening in Yemen. And I tweeted the numbers because I want people from Yemen to give us more data. So I put a number out there that I'm not 100% sure about, but in the hope that I can get better data. And yes, countries could reach out to me or to IHME, and we're happy to work with them.
Thank you very much for that. Do you have time for a last question, maybe?
Yes, I'm all yours, yes.
So did you consider the misclassification of flu cases as COVID? What are your thoughts on that?
Yes, we are. That's a very good. We are concerned about misclassification of COVID, especially early on, to flu or flu symptoms or flu-like diseases, causes, and pneumonia as well, because use of ventilators. So yeah, we are concerned. That's why we switched to adding excess mortality, and we are using countries where we have excess mortality. We're trying to adjust our COVID-19 estimates to the excess mortality in order to account for the under-reporting of deaths from COVID-19, which is true in every country right now. Very good question. Thanks.
Thank you very much. I think that answers all of our questions, unless anyone wants to make any live questions. So please feel free to raise your hand and unmute yourself. Otherwise, I'm giving the floor back to Isabel for the closing.
Okay, thank you very much, Adela, for your contributions and your help. I would like to thank the MediPIET family, especially for being here, connected, and all other people also connected, especially from most European countries. We will be back on June 18th with another useful presentation. And I especially thank Dr. Ali MOKDAD for such an excellent presentation. Thank you very much for your contribution. Keep in touch with the MediPIET countries, because we will be willing to contribute with the data and sharing new views about the modelization of the COVID epidemic. Thank you very much.
Thank you. Be safe, everybody. Bye.
Bye.